Well, welcome back, everyone, to the UHC Pavilion here at Devex as part of our UN General Assembly coverage. We have had a remarkable day already, digging deep into issues of universal health coverage. I'm Raj Kumar, President and Editor-in-Chief of Devex, if you're just joining us now. And I'm joined here by my colleague, Amruta Biatnal, who is an Associate Editor at Devex based in India. Amruta, nice to see you.
Nice to see you, Raj. How are you?
Doing great. It's been a fantastic day so far, and I know some people might be just joining us now for the first time to tune into this session of Partnering in a Pandemic. Maybe you can tell us a little bit more about what this session is going to be about.
Right. As we have seen in the last 6 months or so, organizations have struggled and, they're continuing to really work hard on how to reach people on the ground, especially in remote places. And this is where partnerships really become important. We're seeing unprecedented sort of issues of access and unprecedented issues of barriers that have come up when people can't travel, when, people who used to be on the ground can't be on the ground anymore. So I think this conversation is really timely in the sense that we will explore what it takes to partner in a pandemic and how organizations who've already been doing that in various other contexts have sort of, really changed their way of thinking or how they've adapted and, how that can then be adapted to other contexts going forward.
It connects in a way to the video we just saw, your video that you've done on decolonizing development and a further conversation that we've recently done with the Hilton Foundation on the same theme, because in a way it's about developing systems at the local level, at the country level that are owned and run by the people that these issues most directly affect. And going away from an old mentality of, well, we swoop in when there's a disaster and we bring in foreign expertise and resources. I think part of what we're talking about when we talk about partnerships is really building something that's sustainable and that's demand driven, that comes from the people who are affected first.
That's right, Raj. And in so many ways, the idea of localization is really being tested right now to see how are organizations really relying on their local partners and giving them equal power, equal resources to do what needs to be done on the ground. And again, that, like you said, it links to the decolonization conversation because, this is the time to really show that development is indeed decolonized.
Yeah, I know you've got a visual story you're going to introduce in a moment. And I just want to mention it's from our partner here, Smile Train, who we've had the pleasure and honor to work with for quite a while now. And they're innovative in that, for those who may not be as familiar with Smile Train, their focus is really building the local capacity to do surgery. So rather than saying, hey, let's have American or European doctors and nurses go overseas and actually perform surgeries directly and then come home, how do we make sure local medical professionals get the training and the resource and the systems they need to do their work over time? And we've worked in partnership with them to develop this Duty of Care series that some of you out there watching may have seen. And Duty of Care really digs into these questions of how do you build stronger health systems. So it's all part of our broader UHC agenda here at Devex. But I wanted to mention that and thank them for their partnership. And then maybe, Amruta, you can tell us a little bit more about this visual story we're going to see.
Right. So in this visual story, we'll hear from a practitioner who's on the ground in Nigeria and looking at how healthcare workers are really using technology to continue their training programs, but also how COVID is affecting their work on a day-to-day basis, and what they're doing and how the training that they've already received is helping them through this. So let's go right into the video.
COVID-19 has had a massive impact on the healthcare system. The fear, not knowing enough about it, and its transmission caused us to step down our elective surgical list. So we weren't just doing the routine surgeries, but only doing emergencies and cancer surgeries. We didn't want our regular patients coming in and to be exposed to COVID just because we're coming in for a hernia repair or something like that. We also had quite a number of our staff in our department contact COVID-19 and had to be isolated. Some of them had to be treated. Some of them were contacts of contacts. So we had to step them down from the floor. So it was quite difficult for us. It wasn't always easy for us to get free-flowing PPEs, personal protective equipment, for us to feel that we can go ahead with this case. We pushed and pushed. We eventually got it, but sometimes it was hard. Coming in every day to work as an anesthetist, you have to come in to do surgery. On the personal aspect, it was also a little bit daunting. Coming in, then going back home, then coming in and going back when everybody else at home is on lockdown. But we took all the necessary precautions we felt we had to take, and we came in and did the job. I remember when we had the Ebola crisis a couple of years behind, we weren't quite ready as a country, as Lagos State, and as a hospital. So we were forced to go in and make these preparations for the Ebola epidemic as well. And so when the COVID came, we were able to fall back on our experience with the Ebola. That's why it didn't take this particular center long to be able to say, okay, bring the patients in, that kind of thing. It didn't take us too long because we could fall back. We just went, what are the structures? What do we use for Ebola? Okay, let's try and change that. Let's make this isolation center. Let's, and so we were able to, I think we were one of the first to be able to say, you know what, bring in the COVID patients and we'll take care of them and we'll even operate on them. So we would always learn from, we should always learn from experience, and we should keep on continually training staff. It is so important that all the things we should be doing, washing our hands all the time, should have been the norm. We shouldn't need to teach washing of hands. It should be the normal things we do all the time being healthcare workers. So we need to emphasize it. Even when we get over this COVID, we need to emphasize all those preventive personal health measures that we can take, as well as the added ones of distancing and face masks with COVID as well. More education, practice all the time, and not just wait for when we have an issue and then try and get people in. So more training, I would say.
Welcome back, everyone. We are in Partnering in a Pandemic, and just before we join our esteemed guest on the panel, I would like to introduce my co-moderator, Natalie Dornbach, who's an editorial associate and a reporter at Devex. And we will be joined by Natalie at various points during the event to understand the questions that you, the audience, are asking, and also to understand, what the major points are of the panel. Hi, Natalie. How are you doing today?
Hi, Amrita. Yeah, doing great. Thanks. Really looking forward to this conversation today. And as you mentioned, I'll kind of be monitoring what our audience is saying as well and their take on the issue. So just a reminder for everyone who's joining from across the world to please submit your questions. You can just use the chat box on the platform and we'll have a look at those. There will also be a couple of polls that you'll see up on the platform. So make sure you vote there. And yeah, I'm just really excited for this conversation today. And I think most of us know someone who's had a really important doctor's appointment or even a surgery postponed during this pandemic, and all the ways that this pandemic has highlighted the gaps in those who can actually access care and those who can't. So yeah, really excited to hear from you, Amrita, and from the panelists. I did want to also kind of take your pulse and what you're hoping to learn from our panelists and from this conversation today.
Yeah, you're right, Natalie. This time is so right to talk about the importance of partnerships and access to health, really. So that's what I'm sort of, really excited to explore with our panelists today. I want to understand, how things have worked in different parts of the world, and also how different organizations have adapted to this to the pandemic, and how they've sort of come up with new ways or revised old ways to really get to the people on the ground and make sure that people who need to be cared for have the access that they need.
That's great. Well, yeah, you're joined by a fantastic panel, so I'll let you introduce them, and yeah, you'll see more of me in a few minutes, and looking forward to receiving all your questions. Thanks.
Thank you, Natalie. And now I have the pleasure to introduce our panelists for the day. I'm joined by Dr. Zamir Gray, who's the TB program lead in South Africa at the Bill and Melinda Gates Foundation. Also joining us is Professor Salome Mashwine, who is the head of global surgery and joins us also from Cape Town. And we have with us NK Obi, who's the program director at West and Central Africa at Smile Train, and she joins us from Lagos, Nigeria. Hi, everyone. Really happy to have this conversation with you today. I would like to jump right in and, talk about how the last 6 months have been for each one of you at the organizations that you work in, at the places that you live in, and, really try to understand what are some of the gaps that you have seen emerge in terms of our existing health systems and where partnership really fits into that. So if I could start with you, Dr. Zamir.
Thanks so much, Maruta, and the Devex team for the opportunity to be part of this discussion. I think that the foundation can only execute its work with partners on the ground. And during the pandemic period, we have certainly seen partnerships play an increasingly important role to support the most vulnerable. And I think that what we saw in countries that were not prepared was that people feared going to health facilities. There was challenges with accessing care. There was stigma. There were all sorts of barriers. And that without some of the partnerships that came to the fore, which I hope to be able to talk about, and some of the models that were born out of the crisis, I don't think we've been able to address the needs of the most vulnerable. I think the one partnership that the foundation has taken a lot of care and effort and investment in supporting is the acceleration of COVID Tools Partnership, which is a global partnership between the WHO, the Gates Foundation, the FIND, the Global Fund, UnitAid, the World Bank, Gavi, Wellcome Trust, etc. And I think this particular partnership was in response to the need to make sure that there was equitable access and that no population was left behind. And so the partnership is really trying to ensure that the tools for COVID response, so that's vaccine, diagnostics, and treatment, happen in an optimal way, in the quickest way, but also ensuring that the countries that ordinarily would not be able to afford this actually continue to have access. And just a few days ago, we saw that some modeling suggested that if, for example, vaccines was restricted to those who could afford it, the result would be that the world would have more than double the number of COVID deaths on that single intervention. And so this is really where we see the value of partnerships coming together to protect the most vulnerable.
That's right, and we'll definitely explore more of that as as the conversation goes on. I'd like to come to Professor Salome Mashrine next, and just to try to understand what have you seen as being the biggest gap in partnerships in the last 6 months.
Thank you very much. And also just to add as well that I'm here in my capacity as one of the leaders of the Global Surgery Foundation, which is part of the which is part of UNITA. And so, the past few months have been very interesting, very different for all of us. And so, Global Surgery Foundation particularly, which is all about partnerships and bringing together different global surgery units, institutions, and academics, governments, and trying to find solutions. It's been really difficult and very interesting for a new organization to have to work on all of this during a pandemic. But, some of the things that I think the pandemic has highlighted, it's things that we knew already, the importance of health systems, how health outcomes are really determined by the health systems, preparedness, mitigating, all of these things have been key things. And I think leadership has come out as a very strong point. And so I think having seen through different countries, how do you bring the community together, the stakeholders together? I think these have been very interesting lessons, and seeing how in some cases, even governments or in places where with strong health systems where there hasn't been strong leadership, there hasn't been really good outcomes. So it's been interesting to watch and to navigate all of this. But I think the importance of partnerships, especially with the kind of work that I do and with the organizations I'm involved in, has been, to look at how do you now partner with closed borders, and now how do we come up with solutions? Because the kind of work I do is very practical. It's implementation. And we immediately moved from coming up with just global surgery or surgical solutions to COVID-19 solutions. And how do you do that with partners that are in other countries that don't have access to our country? But I think it also created opportunity for coming up with more interesting partnerships that, allow us to broaden, go beyond what we normally would. And in some cases, we have had to add partners in our countries, for example, funders, digital partners, etc., that we wouldn't have normally looked for. So it has opened up new possibilities of finding new ways of doing things through challenging times, whilst also exposing the weaknesses and gaps that were already there.
Yeah, it's interesting that you mentioned that, that the fact that you found new partners that you hadn't thought of before, and how this time is really encouraging people to think outside of the box and really, look at different stakeholders and see, okay, who are the ones that we've missed before? Why have we done that? And, how can we use this time really to come together? Enki, I'd like to come to you next and really understand from the Smile Train perspective. You've been working in West and Central Africa, where you've sort of seen firsthand how other diseases and pandemics have manifested themselves. So how was it when, COVID really started, and what was the first sort of thought that came to your mind, especially when it came to partnerships?
Thank you, Amorata, and thanks everyone for having me on the panel. I would begin by saying that outbreaks have been occurring, but none has reached the level of COVID-19. In the last 6 months, we've seen rapid and massive increase in the demand on healthcare facilities, thereby exposing some of the weak fragility with the delivery system in terms of equipment, in terms of manpower, and even in terms of the facilities on ground. We've had cases of low testing, and of course, with no routine testing for patients even before surgery. And so it's sad to note that healthcare workers have become infected by the coronavirus at several healthcare facilities, and thereby increasing the already depleted pool of healthcare workers in the country. Incidentally, the few available are so poorly compensated. There is a lot of inequality. There is inequity in the distribution of the workforce across board, where we have many people in the urban areas leaving the large parts and the population underserved. In Nigeria, for example, we have that the number of physicians is at 1.95 per 1,000 population. And this was from the WHO data. And we also found that with the ENSOP project, that 1.65 surgical providers per 100,000 population against the WHO recommended 20 surgical partners per 100,000 population in Nigeria. Now, despite the pledge by the government to increase to 5 points per 1,000 through medical education, as well as increase the national medical health expenditure per person per annum to about 50,000 from less than 10,000. These are yet unfulfilled promises and a major gap which COVID-19 has brought forward. We've had lack of mental health resources. There is a lot of inadequate PPEs like we watched in the video. Some of the hospitals are so poorly equipped. Some don't even have functional ventilators. And of course, we know there's a lot of lack of willpower on the part of government in making healthcare a priority. I recall in 2001, in April 2001 in Abuja, the heads of State of African Union countries made a declaration, which is called the Abuja Declaration, to set a target of allotting at least 15% of their annual budget to improve the health sector. Sadly, out of the 9.5 trillion naira budget of Nigeria in 2020, only 427.3 billion, which is 4.5%, was allocated to the health sector. We talk about lack of investment in health education, in health technology. The government had actually pledged also to invest in cutting-edge technology, such as telemedicine, in all major health centers in the country. And that was going to be through partnership programs with communities and the private sector, and then increase the quality of all federal government-owned hospitals to world-class standard by year 2019. Yet, is another unfulfilled promise, which COVID-19 has brought to the forefront. There has been little or no time for hands-on experience for trainees due to the social physical distance guidelines, just to minimize the contacts, leading to very limited number of staff being trained or being on duty. And so the health sector has since been fraught with continuous neglect and protest over basic entitlements. At the moment, the JHOSUT, which is the Joint Health Workers in Nigeria, are on strike. And what are they striking? They are striking over unpaid COVID-19 hazard allowance. The resident doctors were on strike a few weeks back over irregularities in the implementation of the Resident Doctors Act. So now, coming back home, which is coming back to Smile Train. During the COVID-19, we found that the mission model of care was totally paralyzed. Anything that required flying in a doctor from overseas to care for patients was suddenly not an option. And so while surgeries have resumed in many parts of the country or many parts of the world, travel is still not possible in most cases. And this is where the Smile Train unit model has proved again time and time that it is the best model of partnership and sustainably empowering the local medical professionals. This we have seen that our partners have resumed surgeries in more than 50 countries. So we can't rely on medical missions, that's the truth. We can't afford to offer care in a way that doesn't lead to sustainable systemic empowering change. We have seen the consequences, so we must invest sustainably and holistically. Locally led partnerships are the key. They are more flexible, they are adaptable, even in the midst of a pandemic, and they will go a long way to strengthen healthcare systems to be more resilient for the future. Needless to say, the poverty level increased with the COVID, the inability to access emergent health services, postponement of elective surgeries, whereby cleft patients we are now more at risk of malnutrition, of speech problems, and of course of continued enduring stigma. Thank you.
Thank you, Nk. You raise a really important point of local partnerships, really finding those local organizations who are on the ground, who know the communities, and who can really sort of understand what the context is. And that again sort of brings us back to the decolonization conversations that we're having earlier with Raj to about how COVID-19 is really exposing some of these gaps, but also this gives us an opportunity to bridge this gap and really understand, what people on the ground really need and forge these partnerships that can be sustainable. Like Nk said, I'd like to come back to Professor Salom for a second and, try to explore this a little more and, understand how you have used local partnerships and what the challenges can be. We know what the benefits can be, but, maybe for a minute we can talk about what the challenges can be and how through training and other methods those challenges can be bridged.
And how I always sum it up is, firstly, when you look at global partnerships, the question should be, whose problem are we solving? Is it the person who comes from another country to my country to say, I think you've got this problem, let's solve it? Is it something that is important to us? Do we, have we warmed up to it, or are we simply looking to collaborate because, we know the benefits of collaboration? We all want to be associated with an institution that might give us funding as well. We all want to be part of a publication at the end of the day. So it's important to think about whose problem we're trying to treat. And the problem that we're trying to solve needs to come from the country that has the problem, needs to come from the community that has this need. And any partner should come from a place of having the resources and skills that are required to assist in solving these problems. So I think the whole model that we've used over the years has been flawed, and a lot of it has to do with the colonial history, the colonial past. And so I think those are the things that we really need to look at, because otherwise you've got research which is happening, you've got solutions that are being implemented, but statistics are not changing. If we're looking at global surgery, if we're looking at maternal health outcomes, women are still continuing to die despite the research, despite the resources, despite the funding that has been put into improving the outcomes. So we need to go back and look at why we've got the partnership, what is the reason, what is driving the partnership, and then making sure that these are fair and that they are not driven purely by who's funding it, because a lot of it is driven mainly because of the funding, and the funder has got an upper hand. So there are a lot of ethical issues that we need to look at in terms of the partnerships, and coming up with models and solutions that are relevant to the society we're living in, and that are sustainable. Because if it works for a few months, but afterwards we can't continue with this, then we've got a problem at hand. And also looking at unintended consequences. These partnerships are driven with goodwill. We partner because we want to work together. We're looking at improving outcomes. We're united in the mission that we have, but there are also unintended consequences, and examples like missions. As we know, you might run a mission for a week, but you left with patients afterwards who are having complications, and no one there is able to treat these patients, and having these undesired mortalities and morbidity related to some of the interventions that we come up with together that have not focused on having without sustainable outcomes. So there's so many things that are involved in all of this, but it's ethical issues, it's sustainability issues, and thinking through exactly what outcomes we want from these partnerships.
Right, and thanks for reminding us about how the sustainability of the programs can really matter. Yes, Dr. Zamiri, would you like to come in here?
No, I think that Prof has just made a great point there, and I just want to build on that, because I think that, I think what COVID tested us differently was we cannot parachute relief in, and that the model of we have solutions looking for problems was fundamentally tested, right? Because you couldn't come with a set of solutions, which is something we often slip into. And then we look and try and find the problem that'll fit into that. And I think that what we are seeing, are solutions that were built from the ground up, are government-led or civil society-led, but partner-supported. And I think those are going to be the solutions and the models that show us durability beyond the COVID crisis. And I think therein are some almost design principles for what was fundamentally different about the nature of the partnerships we enjoyed during COVID that we should look to nurture beyond COVID. Because I think there's a real risk that we would slip back to doing things the way we were. And there are a couple of simple partnerships, that I'm thinking about where, for example, the government recognized early on in Cape Town, Prof, you may have heard that, there was a big concern about patients who are on chronic medication. who no longer could access the medication. And we know that that was the same population at highest risk for severe disease and death, diabetics, those on antiretrovirals, on TB medication, etc. And so what the government did was try to think about what other partnerships can we quickly bring to bear to make sure that those patients continue to get the medication. A very unusual partnership that government entered into with Uber, who happened to have spare capacity at the time. And so Uber then delivered the medication to community healthcare worker nodes. And the beauty of this is that the community healthcare workers then delivered the value. And what was amazing, and we all still kind of trying to grasp that just during this pandemic period, 566,442 packages of medication were delivered in a project that the government is now fully committed to trying to sustain, because it's their project that was built through partnerships and support of others. And the feedback from patients is actually what almost, in a way, sealed the deal, is we heard from patients how that has been fundamentally a value adding and, something that government needs to sustain. And so I think the other thing that COVID has taught us is that whatever the partnership is, can we make sure that the P in patient is in the center of that partnership so that we're designing around that.
That's right, Dr. Zamir. And, as we're talking about partnerships and as we're talking about the larger sort of ideas of sustainability and ethics, as you remind us, we should not forget what the patient on the ground really needs and what they are looking for at this trying and difficult time. Which brings me to our first poll question. I'd just like to remind everyone who are watching us that we have a poll going on right now. And the first poll question is about patients. And we are asking, what is the largest barrier to patients accessing care in many low and middle income countries? Is it high out-of-pocket costs, lack of facilities in rural areas, or a lack of trust in the quality of care? And just in a little while, we'll get back to Natalie to look at what you, the audience, have answered. Coming back, we've talked about the ethics of partnerships. We've talked about how local partnerships are important. And Dr. Zamir really sparked this idea of new partnerships like the one with Uber that was forged in South Africa. So I'd like to come back to you, NK, and really understand what are other radical partnerships that we hadn't thought of until now that this moment has really spurred or has made us think of in terms of, really engaging with newer stakeholders.
Thank you, Amruta. Talking about radical partnerships, I will begin by saying that significant and complex challenges require deep collaboration and lasting commitment between partners. And that we have seen the COVID-19 has actually become a very complex challenge where no single solution exists. And so we must all focus on what we do well, but come together and reach a shared collective understanding and framework for solving the problem. For us at Smile Train, the core of our work lies on partnership. And this partnership are usually with local treatment facilities, with our medical advisory councils, the medical advisory board. And this has helped our partners to gain community trust and know the best ways to spread word about our program and for our medical professionals to provide consistently available, culturally appropriate care for our patients. And so for us, importantly, we were looking at how do we elevate the local medical capacity to raise the safety and quality of surgical and anesthesia care within the context of the COVID. And that we have done by partnering with leading speech, nutrition, and cleft coalition to share expertise and to design training. We've had partnership with relevant stakeholders like the West African College of Surgeons, which my CEO, Susie, and Professor Donko will be shedding more light on. We've had partnership with the WHO on the art impact for health. And this is to bring art and culture to the medical environment and create a community of artists and medical professionals to advance universal health coverage. We've had partnership with the Kids Operating Room, the Kids OR, to supply and upgrade 20 pediatric operating rooms across Africa, providing that essential life-saving surgical care to more than 12,000 children by the end of 2021. We've developed competency in palate speech therapy, and that we did in collaboration with the Speech Pathology and Audiology Association in Nigeria. We're also training people on BLS, the basic life support, and pediatric advanced life support, and that we are doing in collaboration with the American Heart Association. We have built self-anesthesia management and provision in low-medium income countries with the WSFA and with our in-house Medical Advisory Board and Medical Advisory Council. And very recently, we signed on a partnership with the Safe Surgery Initiative, and this Safe Surgery Initiative rolling out a surgical instrument repair technician training. Now, this training is a long-term sustainable solution to biomedical technicians to maintain a safe and high-quality surgical instrument inventory. It's so important because I always say that the outcome of a good surgery would depend on the skills of the surgeon and the tools that the surgeons have deployed. And so at the moment, we are piloting it in Philippines, in Ethiopia, and in Nigeria. We've had live box partnership and where we distribute pulse oximeters and the COVID-19 surgical patient checklist to our partners. We've gone into a partnership with the GSK, the giant pharmaceutical company, to establish a toll-free line we call the Cleft Helpline in India and now in Nigeria. And we're also doing a lot to improve the quality of nursing care, and that we have been engaging the West African College of Nursing, and they have given us the CME credit to the bespoke post-operative nursing care training we have started. And we've had very key strategic planning and research infrastructure partnership on global health priorities and policies with the Nigerian National Surgical Obstetric Anesthesia and Nursing Plan, the NSOP project. The Smile Train has partnered with the Federal Ministry of Health Nigeria to establish the first e-registry for cleft and surgery. So there has been a lot of disruptive innovations leveraging on e-platform as a result of the COVID-19. So we needed to sustain non-clinical and academic training activities. We've had the telecleft. The telecleft we did in collaboration with the West African College of Surgeons. And it's been a super wonderful learning journey because it's giving us an opportunity to network, to engage, to educate, to learn, to share experiences and knowledge. And it's also helped to bring to spotlight the complex nature of cleft condition and surgical care and the centrality of multi and interdisciplinary team care. I mean, I could go on and on. The telecleft was intended for 1 week, but due to its impressive success, it's going on now for 36 weeks, which is 9 months. It's amazing. And I would like to say that there's been CME credit to it awarded by the West African College of Surgeons. And we've also had series of, telecleft initiative, telehealth initiative with partners in the Philippines, in India, where they provide virtual comprehensive cleft care like speech therapy, like nutrition, like guidance to our patients. And so with all these partnerships, each have a different purpose, actually, and are responding to different gaps. But then each share attributes that have led to their success. And this attribute is that they are all done in a true, equitable level that are locally led, and they all offer mutual value on both sides.
Right, that's great to hear, and I'd love to come back to our other two panelists. But before that, I'd like to go back to Natalie. Natalie, what are our poll results? Can you tell us?
Yeah, no, it's been really interesting to see what folks think. And yeah, thanks to everyone who voted. And I think the top two answers are cutting it really close. But yeah, so just to repeat the question was, what's the largest barrier to patients accessing care in many low and middle income countries? And most of you said that it's either because of high out-of-pocket costs for patients, or it's actually the lack of facilities in rural areas. So I think it would be really interesting to hear a few examples from our panelists in terms of partnerships that have been able to address any of those two. So either really being able to lower the costs for patients, or increasing access to care and to services at the last mile. So yeah, it would be great to get your take on those results as well.
Yes, definitely, Natalie. Professor Salome, if I can come to you, what do you think is the reason for this, perception with the audience, but also what patients are really experiencing right now?
So, I mean, if I understood that correctly, I mean, it's issues around the perceptions of the patients. Maybe Natalie, can you just, I didn't get part of it clearly.
Yeah, sure, definitely. Yeah, it's Ruta, maybe you can fill in as well. But we were asking what people see as the biggest barrier to being able to access health, whether that's during COVID or not. But really that being high out-of-pocket costs for patients, for services, for accessing services, or actually the lack of facilities close to them. So seeing that this seems to be kind of the perception of the audience, that these are the main barriers, I thought it would be great to hear from you in terms of what are some partnerships that have actually been able to tackle these two issues. And I think it would be great to hear some real examples from the ground.
Yeah, thank you. And I mean, it's and different countries have got different health systems, and so, there are countries that will really protect their patients and enable that patients that they, healthcare, seeing healthcare as a right and not as a luxury, and providing the health care facilities, the healthcare that patients need, resources to healthcare. And so, it's very different, different. I mean, in some countries where they've partnered closely with NGOs, with religious organizations in providing additional healthcare beyond that which the government can provide, beyond that with the public-private healthcare institutions, reducing the out-of-cost for patients. And I think these are often initiatives. This speaks very well to what we do in global surgery. And so we've seen various examples of this. But I think one important thing is also just acknowledging, there's no government in the world, I think, that can provide all the healthcare needs for the entire population. So partnerships are important in providing care, but it needs to be sustainable. It needs to have the patient, the person in mind at the end of the day. And so working with the various sectors and the various people and organizations that can supplement and that can provide extra care and extra help, that has been important. And also quality of care is a major theme as well, because, for example, like with surgical patients, you don't just want to operate and then patients die afterwards. You want to operate and make sure that these are patients that are reintegrated into society. And so the understanding of the patients, of healthcare, of surgical care, investing in preventative care, investing in rehabilitative care, and partnerships that deal with that and provide some of these are very important in improving outcomes. And the better outcomes you have, the less fear patients have, the more people will access their care. And if the care is in places that where people can reach, of course, there'll be greater use. And then respect as well, creating a respected, dignified environment for patients, for people, so that the whole patient experience at the end of the day will be good, will be dignified, and patients will then continue to use the resources that are provided for them.
Right, and you bring up a really interesting point of, how it's not just about what happens to the patients when they come into a healthcare facility, but also what happens to them after they leave, and how, maintain this trust and ongoing trust in the public health system. So like if something like this happens again, or in terms of, if in case of any other diseases, to come that they experience no fear, and also knowing that will get back out healthy. I would like to now take this conversation to Dr. Zamir, to understand how these decisions are made at an organizational level, such as the Gates Foundation. How are local perspectives and local context really taken into account when you're forging sort of like these multinational partnerships? If you could speak a little bit about that.
Sure. Amruta, just before I kind of respond to that question, I just want to reflect briefly on the poll results, because I kind of feel like I think that what COVID has done is not necessarily unearth new barriers, but I think it's put a magnifying glass on the barriers that patients were experiencing pre-COVID. And it's forced us to acknowledge that those barriers exist in a way that compromises their ability to access care, and that we have, in some ways, that our models or our methods of delivering care need to be more responsive and more patient-centric. And the reason I'm saying that is I think that it forced some rethink in terms of what sort of support can we provide to patients, even if patients don't have the ability to come in? Are there mobile tools? Are there digital tools that help us to risk stratify? And we've seen some great models of that come out. Are there models where we engage almost a non-traditional partners? So there's a great project underway to use the footprint of independent pharmacies spread out across the country to enable those that require a test to actually access a test for free. So the commodities were paid for by the private sector, but there wasn't the footprint, everywhere to be able to do that. But actually, there's a great footprint in these independent pharmacies. And so I think that these kinds of models, we need to make sure and continue to advocate that our patients will continue to experience those challenges post-COVID. It's not a 6-month phase, and that we need to figure out how do we not just sustain, but actually up the ante in a way that continues to provide that care. So, Amrita, to come back to your kind of question around how does the foundation, think about and structure and prioritize, some of the work that we do with multilaterals. I think that the starting premise for what we do is all lives have equal value. And so whatever partnership we're getting into, we want to make sure that whatever technologies, whatever tools become available are really accessible to the people who need it. And I think that, again, what's happened with COVID is not so uncommon for many other tools that we've seen, where the people who can pay will access what's available and the best technology and the best tools, etc. And so the example that I gave of the COVAX facility, which is one instrument that the foundation supported, but actually the real hard work is being done by partners like Gavi and CEPI and WHO, etc., is to make sure that lower and middle income countries actually do have access to those tools. Because we know that there are a long list of countries who, if they do not have access to the vaccines, that they will not be able to purchase the vaccine. And so what we've seen, not for COVID only, but for many other things, is that a market failure leads to the people who will benefit most to not have access to those tools. And so whether we're talking about tuberculosis, whether we're talking about HIV or some of the kind of diseases that disproportionately affect low middle income countries, our key criteria is to ensure kind of equitable access, and we will work with a range of partners who have deep experience in making sure that happens. That's not, it's often kind of easier said than done. And, I happen to be in South Africa where we have this dilemma. We see it kind of playing out right now, which is South Africa is the only country where COVID vaccine trials are happening, but South Africa is not considered low middle income, and so will not qualify for the COVAX facility, right? And there's something fundamentally flawed about that. And I think, Prof, you touched on it, which is the best research is happening in many of the geographies, but the delivery and the fruits of those research are not getting to the people who deserve that and who really need that. And so that's another criteria we want to make sure that we're trying to help as best as we can in our limited way, is to make sure that the best research that is being done on the continent actually gets to the people who deserve and need that the most.
Right. Yeah, that's really important. And, it's sort of eye-opening and not surprising in some ways that all three of you have touched upon the idea of decolonizing health and decolonizing development in this conversation on partnerships, which goes on to just, tell us that we can't really think of vaccine delivery, any kind of research and access to care without thinking of these broader ideas of what brought us here and, what are sort of like the ethics that we want to go forward. Before I come back to my panelists for last thoughts, Natalie, can you tell us what questions our audience is asking?
Yeah, absolutely. We've had some really good questions come in, and I actually wanted to piggyback a little bit on what Dr. Zamir just said about reaching underserved populations. And we've had someone comment that he thinks that different able persons and senior citizens, especially in rural parts of Africa, are often left out of partnerships. And this person is asking, so how do we make sure that these types of partnerships that we're talking about here today actually don't leave anyone behind when it comes to ensuring better health service delivery? So I think, we've talked that it's important to make sure we reach these individuals and these patients, but how do we do it? I think a couple of practical examples and kind of lessons learned from your own work would be really interesting. Thanks.
Right, Professor Salome, would you like to take that question?
Yeah, so I agree that, there are a lot of, even whilst, all of this, a lot of what we're talking about is reaching vulnerable populations, but even within the vulnerable populations, there's a lot of disparities as well. And I mean, Zamir says it, you touched on it, and it's the fact that even in South Africa, even though we middle income country, but, there's still not, there's so many disparities that you're dealing with a low income country and a high income country all in one. And there are communities that will be left out, that will constantly be left out. And through research, at least through my research, I've been able to look at these disparities and through research partnerships, initiatives, we're able to pick out those people that need to, that have not been counted, and to put more emphasis and target on those communities. Simple things with a lot of the interventions. I did some projects on PPE, advising on what PPE was needed, working with the biomedical department in UCT. And one of the discussions was, are we going to take it to a hospital that already has got PPE, or are we going to go out to the rural areas, to hospitals that really need it, that really don't have it? And so it's important that even within our countries, when we start talking about our internal partnerships, that we look at the disparities that we have, And another thing that I just also wanted to suggest is going forward, South-South partnerships and changing the model and looking at, what can we do with each other, with other countries that are like us, but may have something that they can bring to the table, and we all work together to address challenges that face us. And again, targeting the disparities that exist even amongst us.
Right. Thanks for that, Professor Salome. I would like to now come to our other two panelists for last thoughts. We've had a great discussion. We've touched on many different aspects of partnerships and how that affects, both the decision makers and the people on the ground who are affected by these decisions. If I can just come back to each one of you now for about a minute to talk about what are you looking forward in the next sort of phase of this pandemic and the partnerships that you're part of. What is something that will keep you going on? Dr. Zamir, if I could start with you.
Sure, thanks. And just thanks again for this really kind of thought-provoking discussion and for creating a platform. I mean, I think part of the great work that Devex is doing is actually stimulating our own kind of thinking and making sure we keep a spotlight on these really important issues. I mean, I guess that what we are seeing, and I think I touched on it a little bit earlier, is I think we run the risk of saying that COVID was a short-lived pandemic. Mm-hmm. And that actually, in a couple of days or a couple of weeks' time, we can kind of forget about this and return to business as usual. I think that it would be a good crisis gone to waste. And so what I really hope that we will be able to do in a very systematic but quick way, agile way, is actually try and harvest the best of what the pandemic showed us and taught us, and make sure that we start to build build that into the way the system responds going forward. And some simple examples to the question that Natalie posed is there are geographies across the world where what we've seen is a relaxation of the regulatory kind of barriers to telemedicine, to telehealth, to pharmaceutical delivery of services. Often those and the relaxation of those regulations have actually allowed the underserved populations and the remote populations to now access care. We are already starting to sense that some of those windows of opportunity are starting to close down. And so I think that what we should be doing is, again, coming back to the concept of, can we just listen to the voice of the patient and have that be our North Star in terms of how we think about a post-COVID era? And I think what we will inevitably hear from that is the models. There may be some models that are kind of interesting. There may be some models that, just didn't work, and we should be honest and frank that they didn't work. But I think that what we should be honest about is the models that did work and serve those populations that are underserved and remote, etc. We should make them a permanent feature of the health system. And we should build back stronger. We should want to say that this wasn't a pandemic that broke the system, but a pandemic that built the system stronger year after. Thank you.
Mm-hmm. Right, Dr. Zamir. You're leaving us with really profound thoughts here. Listen to the patients and really sort of, look at what will make you stronger. Professor Salome, if I can come to you next for your last thoughts.
Thank you very much. And I'll be very short. I think COVID has forced us to tap into our own potential, and we need to build on that and maximize our potential. I think we were very operating at, minimal, what's the little I can do to improve outcomes. And now we've been forced to find solutions, especially as Africans in our own system. And we need to take that out and build on that. We need to look at partnerships from a place of sharing resources, not from a place of who's leading. The person who put with the check is the one that leads. But let's all share resources. Someone will bring the skills, someone will bring the knowledge, someone will bring the money, someone, and look at equitable, at lateral partnerships. emphasizing what we said earlier, that this is not an experiment. We need to be problem based. Let's find the problems. Let's find solutions. Let's not be experimental and walk around with solutions, as Samir put it very nicely. And I want to push that we go a step further and not just say let's be patient centered, but let's be person centered, because all of us are affected by COVID at the end of the day, whether you've got it, whether you've had it, whether you're sick or not. And so being person-centered, thinking of prevention, rehabilitation, all of those, and building a comprehensive healthcare system. Thank you.
Thank you, Professor Salome. Being person-centered, that's one thought that we can take forward in the post-COVID era as well. In case I can come to you next for your last thought.
Thank you so much. I would say that partnership should be a balancing act, meaning that at all levels within the value chain, if global strategies are created without a local perspective, I'm sure they will not be successful. And then if global partnerships happen without the buy-in of the local stakeholders from the beginning, I'm almost certain that it will not get to the desired impact that it could have. And so for us, it's very important that we encourage partnership at all levels. And COVID has made it even more important and very urgent. Secondly, I will say that value has value only when its value is valued. I can repeat, value has value only when its value is valued. Means that no matter the innovation, no matter the investment, no matter the partnership, it can only be successful when the value it has value, and when that value has been valued by all the partners. And so, talking about that, we'll look at the social accountability, we'll look at the policy influencing, we'll look at the partner strengthening, we'll look at the citizen mobilization, talking about patient centricity, talking about partner centricity. It all boils down, we need to fulfill our fundamental commitment to all our stakeholders. And by so doing, we stay resilient through and even beyond the crisis. So for us, this is a wake-up call. It's a wake-up call in every sense of it. We need to advocate more to the government to prioritize the health of the people. I always say investment in the health sector is very important because health is wealth. No matter development, no matter the socioeconomic growth, they are all based on a healthy nation. And so this is the time for the government to begin to walk the talk. And so for us, it's also a time to evaluate perspectives, evaluate processes. Let resilience be our watchword. Let's explore what we all can do to be more proactive. Let us be adaptive. Let us be resourceful. And let us ensure sustainability in a prolonged time of crisis. So thank you so much. This is, for me, a great opportunity. While we are bearing the local content with the global flavor, let us be very optimistic. Let us have it that crisis will always throw out latent opportunities for the most discerning. Thank you very much.
Thank you so much, NK. I have learned a lot today on this panel, and I'm sure our audience as well. I'd like to thank our panelists one more time. Thank you for your time and coming here and speaking about all the issues so candidly. And I'm sure we will keep on reporting on this as Devex, and we will come back to you for more insights. Thanks a lot. And please, as we go into our next panel, a fireside chat, I'm sure you will enjoy that as well. If I can just ask Natalie, my co-moderator, to come back and her final thought on the panel as well, and as we start on the next panel.
Yeah, hi everyone. I'm not sure how everyone else's connection is, but I think Amruta is breaking up a little bit. But while we move from our panelists to our fireside chat, I thought it'd be really interesting to comment on our last poll, where we asked everyone, how can partnerships help ensure better access to care? And I think we actually have a clear winner there, where most of you think that it's by reaching underserved populations. Then after that, we had 24% saying by reacting quicker to a crisis such as COVID-19. And then 20% of you said by mobilizing increased funding. But yeah, I think maybe that's perhaps something that our panelists on this fireside chat could dig a little bit deeper into. But it seems like the key here is really to reach underserved populations. And I think it's something we discussed a lot previously, but would be great to hear more. And yeah, over to you, Amrita. Thanks.
Thanks a lot, Natalie. And now we're joined by two of our leaders from the sector, Susanna Schaefer, who's the Executive Vice Chair of Smile Train. And we're joined also by Professor Peter Donko, who joins us from the West Africa and Central Africa Surgeons Collective. Hi, Susanna, and hi, Professor Donko.
Hi, good morning. Good morning.
Hi, good evening. Hi, Amrita.
Hello, and Susanna, you join us from New York, and Professor Donko is in Ghana, if I'm not mistaken. So this is a truly global panel that we have here, and I'd like to jump right in. We've been talking about partnerships since the beginning of the day today, and this partnership between Smile Train and the West African College of Surgeons is a really interesting one in terms of, how you guys operate and how you guys sort of, work together. So I'd like to start with how the partnership was conceptualized, and how did you really identify what the gaps were and where your collective strengths lie?
Sure. Well, as you heard from my colleague NK in the earlier panel, Smile Train's model is based on sustainable local partnerships and empowerment, rather than medical missions and surgical missions. Our work relies on the strength of the whole surgical and anesthesia ecosystem, including the training and education of surgical professionals. One of the major barriers to care for patients with clefts and surgical patients overall is a lack of surgical and anesthesia providers, and particularly those who specialize in cleft care. The West African College of Surgeons is a key leader in training, education, and research in West Africa and across the continent. The college is the first organization to organize surgical subspecialty trainings in the region. And so it was very natural for Smile Train and WAX, we call it WAX, just a shorter name to shorten for the panel, to build a program to support providers specializing in cleft surgery and cleft care. The first cohort from this partnership has begun, and NK had touched on this, with 7 candidates enrolled in the cleft certification course. And then during COVID-19, when surgeries were postponed and training and education opportunities were limited, Smile Train and WAX adapted to fill a new gap. And you heard NK mention this as well. And we have built upon this partnership to continue non-clinical education and training for partners through the Telecleft virtual lecture series. And this series was originally planned for just 1 week, and it has grown to 36 weeks based on demand and the success of the program. And the program has we've brought this training to almost 1,000 cleft medical professionals. And it has been led by local experts, teaching local experts, and it's given CME credit to professionals in a time when in-person trainings were less common.
Right, that's really interesting. Professor Donko, if I can come to you to understand really, what you think is the value of this kind of training on professionals in your part of the world.
Well, I'll say that it's been immensely beneficial. This partnership with Smile Train, in that West African College of Surgeons felt completely lost when this COVID broke out, because we undertake hands-on training of surgeons, and so with COVID we couldn't do that. And with this initiative, with this telecleft funded by Smile Train, bringing together all these practitioners in the area of cleft care, we felt it was a fantastic opportunity to keep our practitioners and trainees engaged in the cleft environment. And this has enabled our practitioners to remain updated, and also learn new skills which previously they were not able to, and also engage with their patients, like from distance. And as Susan said, this is a college which is really engaged in care, in training, but we lack the resources. And so this partnership with Smile Train has been a fantastic marriage, where there's resources on the other hand to enable our training to take place. And we hope that when this COVID is over, this marriage will be stronger.
Right, exactly. Susie, if I can come back to you, and ask you again, like, how do you think these decisions are made at the partnership level with Smile Train and WACS? We've just talked about decolonizing global health in the earlier panel, and a lot of the major theme that really cropped up for me was how this right now is the time for us to be able to do that, and also a time when these gaps are emerging. But with a partnership such as yours, I'm sure this is something that has been on your mind. So I just wanted to explore that a little more with you.
Yeah, sure. Well, for us, our model is built on partnership, and partnership requires trust. It requires the ability to learn from one another. And for us, it's meeting the local need. It's providing partners such as WACS or a Smile Train partner the funding and resources that they need to treat cleft children in their own communities. And we're there for the support. We're trying to meet the local need, listen to the staff, build the programs together. It's really about being a good partner. And, in the circumstance of COVID and what we've just worked through, it was being able to fulfill the need that they had on the ground to be able to work through this and to provide the services and the resources and the funding that they needed to work through COVID and to be able to be there for patients. Right.
And Professor Donko, how is it that you've experienced this kind of, trust within the organization, and how do you then pass it on to the people that you care for? I'm trying to understand if it's a pipeline that comes from organizations such as Smile Train and then travels down to the people on the ground.
Well, what I would say is that with Smile Train, there's been a demonstration of respect between the Smile Train and its partners, and also even the WACS. There's been a lot of flexibility shown in the way this whole partnership has worked. There's been a willingness to accept feedback and to give feedback. And there's constant engagement, and so we always look to see how will this engagement benefit both sides. I think it's not enough to say that Smile Train has money it wants to give, but we ask ourselves, is it benefiting Smile Train? Is it gaining? Is it helping it to achieve its mission? So this is through this constant engagement and this kind of questioning, we try to get to the best outcome, and we let our trainees know that they must ask those questions, they must seek those, ensure that there's respect all around. And that is how we believe that we'll go forward. Yeah. The communication must be sustained all the time. Yeah.
Right, and that brings me to my next question, which is to you, Susie. And when we talk about global partnerships such as this, there's sometimes a fear of resources and information and knowledge going from the global partner to the local partner. But I'd also like to ask you at this point, what is it that you have learned from your local partner in this case, which is VAX, which has then influenced your other areas of work as well?
Yeah, well, each region is different around the world, and Smile Train is a global organization. And I think, in the panel earlier, you heard the discussion between, looking at things globally and then looking at needs on the ground. And, for us, it is being able to meet the needs on the ground, because it's, the cleft is the same, but the needs on the ground are different in each location. So, with that, you have to be able to listen, you have to be able to adapt, you have to be able to pivot, you have to be flexible. And so much of our model is partnership. And so, we keep going back to this, the trust, the openness and communication, having your ear to the ground. I mean, we're fortunate at Smile Train. We have staff in many of the countries where we do our work. They work tirelessly to meet the needs of the local partners, but that's what it's all about. It's we obviously want to be there to help children who don't have access to care. We want to help families who are desperately trying to get their children access to care. And that's what we're enabling and empowering. And we do that through partnership. That is our model. And, we're there for our partners. It is empowerment. That's what we're delivering.
Right. And just being there can be so important, and just placing that trust in your local partner can be so important. And, in my reporting, at least in the last 6 months, just on COVID, I've seen that, that is one issue that keeps coming up, that, you have to trust the people on the ground, and, how decisions that are made at a sort of global level don't really carry down, or, don't take the local context into consideration. And that is what sort of holds back on the progress of some of these programs. So Professor Tomko, if I could come back to you and, ask you in terms of what your experience has been, and what you would point out as sort of like this biggest strength of working with an organization like Smile Train, and really taking those global resources and using them at a local level.
Well, I think one of the biggest benefits is the fact that Smile Train has been interested in building human resource capacity, in addition to actually giving money for those who are able to carry out treatments. They're actually interested in developing new human resources, training, and I believe that there's also there's a sustainability plan for their programs, and that is something that we are also very much in support of. Smile Train regularly evaluates its programs from time to time, and I think in order for success to be achieved, there has to be what I call an evaluation metrics. You must have a way of determining whether a partner is doing well or is not doing well, and there are regular audits that take place, and there's also cultural sensitivity. A lot of the program officers around the Africa are from the local region. They speak the language, they understand the culture, and therefore are less likely to offend. And also, so these are things that really go to ensure that we have a very strong partnership, and they really overcome many of the challenges that beset a lot of partnerships that fail. So I would say that with that kind of approach, the future looks pretty good. And I think many organizations must learn from that kind of approach. Thank you.
Yeah,
that's really great to hear. And we could just talk a little bit about, what are the challenges sort of at a infrastructure level, or, at sort of like an ecosystem level that you find that you've had to cross to sort of get to this level that, other organizations such as Smile Train who are planning to take on an initiative like this can benefit from?
Can you repeat the last part, Amruta?
I was asking, what are the challenges that you have encountered at an ecosystem level within the international development sector that, other organizations such as Smile Train who want to take on an initiative like this can learn from and sort of, adapt that into their own work?
Well, it's, I feel like we keep going back to the same important part, which is trust. And, so many things have to align for partnership to work cohesively. And I think other organizations can easily adapt models as long as they are set up accordingly and are able to empower, local partnerships so that together you are working to meet the need of those that you are trying to serve. It's important that things are led at the local level. If they're led at a global level, you're doing it from a global perspective. But, it's the key piece to this is that local direct partnership. And, that's what we have with WACS. That's, what our relationship and setup is with our partnership with Dr. Donkor and his medical institution, and how we're able to deliver on cleft care for patients in Ghana.
Thank you so much, Dr. Donkor. We've learned so much today about, thinking at the local level, taking the global resources and really using them with trust and, with real sort of investment in the community. I'm sure our audience have learned a lot as well. Thank you so much for your time. And, we'll keep coming back to you for insights. I'm sure our reporters at Devex will keep coming back to you. Thank you.
Thank you. Thank you, Amruta.
Hi, Amruta. I'm back. That was a great conversation. I'm remembering last year, Susie and I having a similar conversation in the UHC Pavilion in person in New York during the UN General Assembly. I definitely missed that chance to be in person with all of you, but you really took advantage of the virtual opportunity to have so many voices from around the world, which really is such a key part of what this session is all about. I would just add one observation, based on my experience with Smile Train and so many other similar organizations, and that is that this kind of systems work is really hard. And if you haven't been investing in it for years and years and making it a priority, it's easy to talk about it, but there aren't that many organizations that have really made it part of their DNA, the way that they actually work. And now in an emergency like this pandemic, you can see the benefit of having built out those systems, the ability to deliver without having to send in international expertise all the time, that you could actually root things locally, make them sustainable, address real challenges, and provide the kind of direct voice to your patient and to the healthcare professionals that are so important. So Amruta, it was a great discussion, and I'm looking forward to much more in the rest of this week.
Right. Thanks, Raj. Same here. I look forward to all our conversations at the UHC Pavilion. I also feel like, it's really interesting how all of these discussions keep coming back to the idea of decolonizing health. And like you said, you had the same conversation last year. So a lot of what our panelists said was none of this is new. These are not new questions, but this is the time to look for new answers, and our partners are doing that. And we at Devex, with our reporters all around the world, will keep covering it.
Absolutely. Yeah, let me just add my thanks to all of our partners for today. For those of you who've been following the UHC Pavilion all day, we've worked together with partners like BD, MSD, Smile Train. We very much appreciate the chance to work with them to elevate these issues. You're going to be hearing from other partners that we brought in for the whole UHC Pavilion this week, from SEED, from Takeda, World Vision, Plan International, the Japanese Organization for International Cooperation in Family Planning, United for Global Mental Health, AstraZeneca, Digital Connected Care Coalition, and Transform Health. All of these organizations help make this kind of programming possible for the broader Devex community of 1 million development and health professionals around the world. So we greatly appreciate the chance to partner with them. We will be back here tomorrow, 7:30 a.m. Eastern Time, to kick off the second day of the UHC Pavilion. You'll hear, in addition to some really exciting panels, my interviews with Mark Lowcock, the UN Humanitarian Chief, and UNICEF's Chief, Henrietta Fore. Those are in addition to the interview we heard today, where I interviewed the Secretary General, Antonio Guterres, all as part of Devex's comprehensive coverage on the sidelines of this year's UN General Assembly, a very unusual year for the UN General Assembly and a highly consequential year. So we appreciate all of you being a part of this. Continue to follow it online at #UHC Pavilion. And thank you. Be well.